We're going to move off of chemotherapy as a first-line backbone for advanced non-small cell lung cancer with immunotherapy and talk about the role of dual checkpoint blockade with PD-1 and CTLA-4. We've had some, again, some very thought-provoking data published in the New England Journal of Medicine recently with CheckMate 227. Sanjay, you want to walk us through that data just briefly?
Yeah, thank you. So CheckMate 227 is a large trial. It's quite a complex trial. Aiming to answer several questions. And it builds on the background that Bristol have, that the potential for combining a PD-1 with CTLA-4 inhibitors with IPI and Nivo may have a potential superior efficacy than just each as a monotherapy. And in 227, patients with advanced disease were randomized to either a combination of Nivo and IPI, or histology-specific chemo with PFS and OS as co-primary endpoints. And outcomes have been presented according to the PFS, according to PD-L1 and the tumor mutation burden. Because at the same time as all of this has been going on, we've been having a number of academic data sets which have generated a nice signal that the tumor mutation burden, defined as the number of non-synonymous mutations per megabase, seems to be influencing the benefit from combined immunotherapy. And what the data have shown is there seems to be a potential benefit for Nivo-IPI versus chemotherapy, but potentially restricted to those that have got the high tumor mutation burden, defined according to the 227 data set as patients with 10 or more mutations per megabase. But at the moment, this is restricted to a PFS endpoint, and we have not got any overall survival data as yet.
So a very nice review. Where does that leave TMB as a biomarker? Is this something that we should be doing? Is it for research use only? Is there ever a time in the treatment continuum of a non-small cell lung cancer patient where it makes sense to do it off of a trial? Anyone want to tackle Sanjay?
Well, I think we're at the beginning of the TMB story. Yeah. This is data which are exciting, new. I mean, one of the key aspects of the whole TMB story is that TMB positive patients, whatever your definition is, probably represents a separate group to those with PD-L1 expression. Ram, you've been involved with the trial as a Solange, which has demonstrated that TMB high patients are a separate group of patients to PD-L1 strongly expressing patients here. So, we do have different groups of patients. Now, the challenge is defining TMB, ensuring we have homogeneity in what the definition of TMB is, and how we can implement TMB in routine practice. Because in 227, the application of TMB was retrospective to outcomes. Patients weren't randomized on the basis of their TMB. It was a retrospective analysis by the TMB status.
So I want to draw on something Sanjay said, which we found in 227 and other studies as well, which is the high TMB group and the high PD-L1 group of patients are not one and the same. There's a direct discordance in who is high PD-L1 versus high TMB. So what I think TMB does is help you select a subgroup of patients who don't have high PD-L1 but could still benefit from immune checkpoint inhibition. Even among the low PD-L1 group, we now have data that if your TMB is high, you actually have better outcomes with immunotherapy combination compared to chemo alone. So I think we will be studying this further. We all agree that PD-L1 expression is an imperfect biomarker, and maybe TMB will turn out to be another imperfect biomarker, but will be helpful to select regardless treatment for certain patients.
I'm quite convinced about this TMB data myself, in the fact that we'd like to identify for our patients some modalities of treatment which might kind of delay the exposure to platinum-based chemo. We can see although the magnitude of toxicity is high grade, by using immunotherapy it's still and always significantly less than platinum-based chemo. So if we can really identify, and the problem, like you said, is really how we can routinely perform or assess TMB and have a a result in a decent time frame. In most of the places in the world, it's still not feasible. But once it will come, because it will come in the course of probably next year, there's many efforts of harmonization. When it will come, it will just complete the picture. And we will have more data across other trials, but complete the picture. I'm sure there will be a nice algorithm allowing us to classify patients according to what could be the best first treatment option. I'm sure Ipi-Nivo will come. It will come for negative PD-L1 high TMB. And it might come also in some subgroups that platinum-based chemo is the best thing we have, right? So it will help us really classifying patients, and we should not just feel beaten by the complexity of a new biomarker. Remember how PD-L1 was complex. Now we can move with TMB and try to be rational about it.
So at my institution, we have moved to an in-house NGS that now calculates TMB. I'll be very honest with you, I'm not sure what to do with that data right now. I think you're right. I think after more refinement, we may have some clues and hints how to use this. Is it in the high TMB, low PD-L1s where patients are offered dual checkpoint blockade? I think we're still, as Sanjay discussed, I think we're in the very early stages of understanding how to implement this biomarker, either in tissue and, dare I say, blood, with some of the trials that were presented at ASCO with the BFIRST trial looking at TMB off the blood.